Okay, I will start playing time and the time is set now. I'll just forward the thing, which is just simply nothing. Open here. Okay, Dr. Ola.
Yes, okay.
Just few
I
seconds.
can see it's
Wait, 1 minute. I want to ask Dr. Along with this, do they tell anything like the age of the child or anything in the video station? Do they give any
A
information?
10-year-old child who had a 5-day-old history of a bug bite. So that's it.
10-year-old child, 5-day history of bug bite. Okay, so now 6 minutes time, right? Should I alert at 3 minutes or no need?
3 plus 3, yeah, it will be better.
No, I think there is nothing like that. But they are asking you 6 questions like what are your clinical signs, what you can appreciate. Okay, what relevant history you will take. Okay, what is your
I think
diagnosis?
there is an alarm after 3 minutes. The 3 minutes left.
Yeah, no,
In the
that's
station flow chart, it's given.
3 minutes. You
Yeah.
can see as many as time you want to see the video.
Yeah.
You want to see in whatever time you want to see. After 3 minutes, we will start throwing questions. What
Yeah.
clinical signs you observed? What relevant history you want to take? What you want to examine in the child? What are
Yeah.
your differential diagnosis? What investigation you will run? And how is your management plan?
Yes, these are 6 common.
Yeah, no.
So
Yeah.
I don't think so there are 3 minutes in this one. In this one, no 3 minutes.
In the station flow chart, it's written in the first 3 minutes. They'll ask you
What?
about eliciting the child and differentials. In the next 3 minutes after the alarm, they will ask you about management.
No,
It's
3
fine if
minutes.
there is
only
no
for-
alarm to be
only
put. It's fine. We'll go ahead.
No, only 3 minutes, and then
6 minutes. Yes, this is what I know also. Yes. And yeah, we will reconfirm it. We may.
Yeah.
Okay, I'm just setting for 6 minutes. Just go for with the questions. Okay, you can start, Dr. Ola.
Okay, I can see a school age children, 10 years old boy who's lying in the hospital setting. He's looking quietly unwell, and there is obvious protrusion of the left eye, as well as I can see there is redness bilaterally. With the abnormal movement of the eyeball, which seems more in the left side, he's unable to move his left eyeball upward and laterally. He's connected, I can see he's connected to IV cannula. So I want so there is a protrusion of the left eyeball with the ophthalmoplegia. So I wanted to ask about the onset of this complaint, progression. What about the eye? Mentioned there is diplopia, blurred vision. I want to ask about any headache, vomiting, any seizure, develop weakness in any side of the body. Also any ear pain. I want to ask about fever, yes, and the previous vaccination, contact. There is a sort of a bug, insect bite, any previous history of allergy.
And in examination, what will you see?
So yes, in examination, I want to do general examination, his well-being, vital signs, temperature charts, any signs of sepsis, and the detailed ophthalmological examination for the pupillary reflex, extraocular movement, formal testing, H-shape testing, looking for ophthalmoplegia, as well as fundoscopy examination. I will look for the signs of increasing intracranial pressure, any hypertension, bradycardia, irregular breathing, ENT examination to look for any origin. Okay, and also general, also detailed neurological examination to look for any focalization.
Right.
Complication like okay, complication of the brain abscess. Okay, so my type of differential diagnosis, it will be orbital cellulitis. This is top of differential diagnosis, as there is a protrusion with the ophthalmoplegia, diplopia, and second, less likely to be periorbital cellulitis. But in periorbital cellulitis, there will be normal vision and the normal eye movements, other insect bites, and it is only it is unilateral. If it is bilateral, maybe I will think of with this edema, nephrotic syndrome, and other any reason for hypoalbuminemia. And also we'll look for the complication of the orbital cellulitis.
Orbital cellulitis.
Yes, complication. I'm fearing of the intracranial abscess, intracranial extension, as well as any a visual impairment affecting the vision. Also, any I want to, maybe the origin, maybe it's mastoiditis and extension to the. Okay, and
So how will you manage
yes,
this?
for management, first of all, I want to investigate this child, as there is ophthalmoplegia. I want to go with the CT brain. We'll do a basic investigation to look for any inflammatory marker, white cell counts, any ESR-CRB, he's sick, febrile. I will do sepsis workup, blood culture, and okay. I will involve the multidisciplinary team.
Okay, which are the conditions you'll do for CT scan or MRI when you go in
Yes,
for
I want to look for the orbital cellulitis and the extension, intracranial extension. So after taking sepsis workup, I want to start immediately antibiotic, for example, ceftriaxone or the cefotaxime. Involve early involvement of the consultant in call, will involve the ophthalmologist, and if there is any original reason, ENT will involve the ENT. Okay.
So how long will you give if only ceftriaxone, if child is toxic, any other drug you would like to add?
Okay. I can add also metronidazole to cover interrupts.
Minutes, but you can continue.
How long will you give this if this is orbital cellulitis?
For 10 days, at least 10 to 14 days. IV.
Okay, total duration of antibiotic?
Total duration
going-
10 to 14 days. IV antibiotic.
Okay. And if there is bone involvement, how long will you give?
For 6 weeks, 6 to 8 weeks if there is bone involvement.
If there is penicillin allergy, then which drug?
Yes, if a penicillin allergy, I will give clindamycin or ciprofloxacin.
Okay, if this is only periorbital cellulitis, means preseptal, then how long will
Yes.
antibiotic?
For 7 to 10 days. I can start with the augmentin.
Yeah.
If he's tolerate oral, I can give oral antibiotic, and if any contraindication, the patient not tolerating oral antibiotic, or he's sick, any vomiting, we will give IV.
Yeah, it's done. Thank you, Dr. Yes, Dr. Ola, it was alhamdulillah done very nicely. You almost covered all the points. Just here or there, you missed one or
1
two.
minute.
You did not.
Dr. Muzna, there is some problem in your connection, or there is any headphone or something like
Now-
that. Can you just check?
Now am I able? Am I clear right now?
Yeah, now you're okay. Yeah, go ahead.
Okay, I'll just do a bit. So I said Dr. Ola, mashallah, she did it very nicely. She almost covered everything, just one or two minute points which were missed here and there. And in the management, I would like to just correct a few things. Just color vision is one thing, red-blue color vision gets affected. So while telling entire visual thing, you said about visual acuity, visual field, extraocular movements, you told about fundoscopy. Just red-blue colored vision gets affected, and that is lost early. In fact, that is monitored if you are suspecting periorbital cellulitis. So that has to be seen twice a day to know whether that is going into orbital, because this is the earliest sign of orbital cellulitis that is taking place. Rest, all your points in the history were done very nicely. Even examination, you covered everything. Vitals, eye examination in detail, CNS, ENT, you covered everything. Even for the investigations, you started with the radiology. Ideally, it should have been CBC blood culture, but it's fine. And you even told the indication of that. Regarding management, just that the total duration in orbital cellulitis is 21 days. The drug of choice is ceftriaxone. If the child is toxic, you go into clindamycin. If he is allergic, then the choice is ciproflox plus clindamycin. Both of them for 3 weeks, that is 21 days. And if it is bone involvement, then as you rightly said, 6 weeks, it has to be done. And if this is simple periorbital cellulitis, then as you rightly said, the drug of choice will be augmentin, amoxiclav, and that will be for 14 days, that is 2 weeks. And you can shift to oral whenever the patient is comfortable with
Augmentin, when you said augmentin?
For periorbital cellulitis, it's augmentin.
Okay.
and it should be given IV if it is really severe periorbital or the child is not improving, then IV augmentin, and you can shift over to oral, and the total duration will be 2 weeks. Rest all things, alhamdulillah, you covered. Very nice.
Okay, thank
And
you.
all these guidelines are there in PDA guidelines. That's only one page which is to be read. It covers everything.
I have
Yes,
just some concern regarding differential. She said, mashallah, she did very nicely everything. Regarding differential, top is definitely orbital cellulitis. What about second and third? Why not? It's an intraocular tumor. Periorbital cellulitis, keep at the down list because this does not present with ophthalmoplegia, okay, and will not be having this much proptosis. Eye will be normal, movements will be normal. This is a clear visible ophthalmoplegia, upward lateral movement of the eye is not there, swelling, redness. So orbital cellulitis, 100%, first diagnosis. Why not? It's a unilateral, so intraocular tumor. That could be like retinoblastoma. It present early, but could be diagnosed late. Okay, so second, I believe then examination wise fine. And she asked about vomiting for any focal neurological deficit. That would be a classic interpretation for that. That's fine. But only looking for viral or periorbital second or third, I think if we can add intraocular tumor unilateral, that would be, in my opinion. So others can give their opinion. And there is extension of tumor, as the Dr. right. Yes, she is very right that neuroblastoma may present with the eye distant metastasis in the eyes. What do you think, guys, for second or third differential?
yes,
Trauma
yes, agree.
could be.
Yes, trauma could be, yes, and this tumor also, tumor, trauma. Yes.
And what about this ophthalmoplegia? Which nerve affected? I cannot appreciate it.
Ophthalmoplegia is the term that's being given to the extraocular muscles. Ophthalmoplegia is external as well as internal. So either one or either all of the muscles could get affected. So sometimes you see, like in this patient, upward and lateral movement being affected, while medially child could see. Okay, but upward and lateral are not there. So either a part of third nerve, like that goes with the upper movement, inferior oblique. Okay, or lateral abducent. It also goes in the favor of tumor that if there is a cavernous sinus hemangioma or hemorrhage or anything that present with the longest 6 nerve abducent nerve palsy, because it is the longest intracranial course. So that will be having a lateral paralysis of the movement laterally will be affected, or there will be no movement. So, and internal ophthalmoplegia is the movement of the eye muscle, ciliary and iris is the one that being affected is called as internal ophthalmoplegia, and external is the other extraocular muscles. So if they go in detail, normally they will not ask about that. But if you know, only simple extraocular, external, intraocular muscle, that is only 2, ciliary, and for the iris, there are muscle sympathetic fibers to be supplied by third nerve. They could get affected, and then iris will not be dilated, cannot find a proper movement of the iris, and pupil will not be dilated if the sympathetic fibers to the pupil will be destroyed or damaged due to any reason.
One of the complications could even be cavernous sinus thrombosis, which could kind of cause this kind of.
Yeah, even sinusitis patient, recurrent sinusitis, they present with cavernous sinus thrombosis as well as orbital cellulitis. But that comes in the differential of orbital cellulitis already. So that is the cause for orbital.
Cavernous sinus, usually it is bilateral proptosis, and in unilateral, I don't think it will be. I mean, causes of unilateral proptosis versus bilateral is different, I think.
Yeah, you are right also. And sometimes we are asking among investigation that pituitary fossa to rule it out among investigation. Normally, if it's pituitary fossa, so bilateral eyes will be involved if there is a tumor at pituitary fossa level, because the fibers, optic nerves are decussing at the level of pituitary fossa both. So, I mean, so tumor can cause problem in both eyes, but you can defend your diagnosis. You can do CT or MRI for pituitary fossa in addition to generalized brain CT, and CT sinuses that can be added. Otherwise, she explained very well everything. Thank you.
Okay, any other comments before we end the meeting?
No, nicely done. Video, she did very nicely. Thank you. So tomorrow you will conduct at the same time, Dr. Fatima?
About tomorrow,
Okay, we'll
I
announce.
don't know.
Okay.
I
Okay.
will I will announce in the
Thank
group.
you, but for today, thank you very much. Yeah. Okay. Yeah.
Okay.
Yeah, thank you. That was a nice session.
Yeah.
Okay, thank you.
Thank you.
Thank you.